So I'm going to twist it around a little bit. So firstly, just to introduce the topic, what are the major questions here in the adjuvant setting at the current time? And I think the big one and the side that we're supporting in favor is does combination treatment work and should we be using it? Secondly, is there a value to the routine inclusion of adjuvant chemoradiation? Is there a value to the inclusion of a targeted agent? And perhaps what wasn't touched on in the last topic, but to me is where I think the field is going, is the whole question of neoadjuvant therapy. And we have a little bit of a disconnect in that we think about combinations there routinely in neoadjuvant, but yet in adjuvant we're still stuck in the single agent era. So what are the current standards? Well, Jordan did a nice job, so I won't belabor this, but CONCO-001 is a well-conducted randomized phase 3 trial, and it states the current standard of care, but the outcomes are pretty modest here, right? So our endpoint was disease-free survival, as was pointed out. Admittedly, gemcitabine does double disease-free survival. There was a more modest improvement in overall survival, perhaps mitigated a bit in that most people on the control arm would have gotten gemcitabine in this study. So arguably, it might have been a little bit bigger. But at the end of the day, look at what we're looking at, that we have 12% of people alive at 10 years from their diagnosis. Most people, sadly, are dead of pancreas cancer. So clearly, while we have a standard, we need a better one. So that's one choice. The other choice comes from the SPAC1 study, which does indeed show us that 5-FU and leucovorin, compared to no chemotherapeutic, is about of similar magnitude of benefit compared to gemcitabine, and that was very nicely shown in the SPAC3 study, although the 5-FU leucovorin arm, as was mentioned, was more toxic. And in truth, we've adapted that for where gemcitabine isn't administered to say that an infusional or an oral fluoropyrimidine is the substituted choice, and just sort of ignore the fact that this was done with Mayo Clinic 5-FU and leucovorin. So we have equivalency of gemcitabine to a fluoropyrimidine. What about chemoradiation and where that fits? It wasn't touched on at all in the last talk, but I just want to say it has a very mixed heritage, with the original GITSIC trial suggesting a value, the follow-up European study negating that value for the most part, and with the SPAC1 suggesting that there was in fact potentially a detrimental effect to the routine inclusion of radiation. Now that's been tortured a bit because there were some issues with the study design and quality control, and the rates of local recurrence were very high for the group of people who received radiation. And Mike, who's in the audience, did, I think, an editorial on this at the time, and did a very insightful job in terms of dissecting the details of this study. So where does that leave us in North America? We've had a follow-on study which looked at 2 regimens, essentially was asking a chemotherapy question and suggested that there was a trend in support of gemcitabine, but not statistically significant, doesn't answer the radiation question. So that leaves us with the following. So our choices in 2015 are 6 months of gemcitabine, 6 months of a fluoropyrimidine in its original format, 5-FU and leucovorin, but as we said, extrapolated and adapted. And where does chemoradiation fit? That may be answered in the ongoing North American study, which is about nearly 400 patients accrued at this point, which is gemcitabine plus or minus chemoradiation. But the bottom line here is these patients are sadly going to not live for more than 2 years for the majority, and the absolute magnitude of benefit is less than 10%. So yes, it's the standard, but we have much work to do, right, to break this 2-year barrier for patients with this disease. So moving to the metastatic era, yes, combinations work better, and they improve tumor response, progression-free and overall survival. And yes, they are at the extent of increased toxicity, but just one point to mention that wasn't highlighted, in the metastatic FOLFIRINOX study, that quality of life was maintained better for longer when disease was controlled, right? And this is something we see every day in our practice. So I would also sort of make the argument here, extrapolating to the adjuvant setting, and Jordan, you said it yourself, that if people are alive with recurrent disease, that they can be sick from their disease, and that is true. So I'm not saying we should be doing this in 2015. We shouldn't until we have data, but clearly there's a strong precedent for thinking that what is working better in the adjuvant setting is going to translate into improved outcomes in the adjuvant setting in this disease. And the two trials we've shown and you've seen, and I just want to pick up on the questions being asked in the adjuvant setting. Jordan showed a different format of this, but perhaps the three that are most likely to change outcomes are the combination cytotoxics. Right? We've spent a lot of time in the last talk looking at targeted agents, but in truth, we haven't established a value for the average patient with pancreas cancer that a targeted agent works. But there is a real potential value that a combination of cytotoxic therapies in earlier stage disease may improve outcomes. So neoadjuvant therapy, as I say, I think that's where the future is. There's a lot of rationale in pancreas cancer. Systemic failure rates being very high. We avoid subjecting people to surgery in the first place if they aren't going to benefit from that. We can get more treatment into more patients. We know that for people who undergo adjuvant therapy, about a quarter don't actually get the treatment, and perhaps if that group was dwindled down, then the benefits from even the current standards might improve. And there's data certainly with chemotherapy and certainly with combination of chemotherapy and radiation showing that R0 rates are increased, lymph node positivity rates where radiation is included may be down, local recurrences can be less, and there is oncologic downstaging. And there are two studies that are being evaluated now looking at adjuvant versus neoadjuvant therapy. The NeoPAC study is looking at gemcitabine and oxaliplatin, and an Italian trial is looking at their regimen, multi-drug combination of cisplatin, epirubicin, David, fluorouracil and gemcitabine. It's not dead yet, and we'll see. So looking at an adjuvant alone, neoadjuvant plus adjuvant, with a control arm of adjuvant gemcitabine. So moving here to the conclusions, yes, single agent therapy is the standard of care, but we have very modest bars at the moment and very modest outcomes. We clearly need better therapies, and I think, and I'm not advocating for treating patients with combination therapy outside of studies, and I think that point is to be emphasized, but at the end of the day, yes, the combinations are more toxic, but I think most patients, and I would suspect a majority of physicians, would trade this off in the adjuvant setting if they're going to live significantly more. So while it's not a standard now, I think it will be in the future, and I think our use of neoadjuvant therapy is going to increase. And I'll leave you with this. So this one is especially for Jordan, as I know he's a dog lover. These are therapy dogs at Memorial. I think they're absolutely gorgeous. Thank you.